shown that a loss of HDAC2 is important for steroid function in adenocarcinomas from patients and also in dogs with Cushing's disease. So just to show that HDAC2 can be important in steroid responsiveness. If we wanted to try and get a drug, which I guess one of the aims of this meeting is looking at health disease and maybe getting drugs that could modulate epigenetic actions, then maybe modulating HDAC2 activity could have some effect. So here we're just looking at a Western blot taken from bowel macrophages from patients with COPD compared to healthy non-smokers who are age-matched. And we can see this loss of HDAC2 expression. If we overexpress HDAC2 back to the level that we see in the healthy non-smokers, what functional effects do we have? And here we see in the COPD patients very little steroid responsiveness. If we overexpress HDAC1, we have no significant effects on steroid responsiveness in the COPD patients or cells from the COPD patients, whereas if we overexpress HDAC2, we now see an ability of dexamethasone to suppress cytokine release. If we do the converse experiment and take cells from the lungs of healthy non-smokers and do siRNA against individual HDACs, again it's HDAC2 that was the one that targeted steroid sensitivity in cells from these COPD patients. Of course, that's not really a feasible drug process, trying to take cells out, overexpress or knock out genes and put them back in. Sam Lim and Borja Cosio had, in a clinical study, had shown that theophylline, which is generally used as a bronchodilator, but at low concentrations, subbronchodilator concentrations, has an effect on repressing inflammation, had noticed that it also affected HDAC2 expression. So in an in vitro experiment where you stimulate a cell with inflammatory stimulus such as R1 in the presence of oxidative stress to try and mimic the effects you see in COPD, even high doses of steroids have very little effect on cytokine release, but certainly low concentrations of steroid or low concentrations of theophylline have absolutely no effect at all on cytokine release. But a combination of both of these appears to give a synergistic suppression of cytokine release, which is probably HDAC mediated because the non-selective HDAC inhibitor trichostatin A could reverse the ability of theophylline and low-dose steroid in combination to suppress cytokine release. John Marek went on to show just at the promoter level using chip assays that again there was this enhanced P65 recruitment and acetylation, acetylation, not recruitment of P65. Again at the CXCL8 promoter in the presence of, in this case, cigarette smoke rather than hydrogen peroxide. Neither steroid nor low concentrations of theophylline had any effect on the acetylation status here, but the combination of the two drugs was able to suppress acetylation under conditions of oxidative stress. We've subsequently gone on in collaboration with Yasuo To and Kazuto in Tokyo to look at an animal model of this to see whether theophylline could have any effects. And here we treated animals for 12 days with cigarette smoke before we intervened with the drugs. So this is a therapeutic intervention protocol. And we could see that neither drug, a low-dose steroid or a low-dose theophylline, had any effect on bowel macrophages from these patients or neutrophil recruitment into the airways of these animals, but the combination of the two drugs gave a significant inhibitory effect. And at least in the peripheral lung tissue, there seemed to be an effect of the combination on HDAC2 activity, which was slightly more than we saw with the theophylline alone, although this didn't reach statistical significance. Taking this on to the clinic, Paul Ford and Andy Durham have just recently completed a clinical study where they gave patients a low-dose inhaled steroid and a low-dose theophylline and looked at HDAC activity, in this case in peripheral blood monocytes. We tried to do this in bowel macrophages, sputum macrophages, and we didn't really get enough cells to get meaningful data. But we had a 9-fold induction of HDAC activity in the presence of the theophylline and steroid. Functionally, there was a suppression of inflammation, at least in sputum neutrophils, which is not seen with either of the two components, fluticasone or theophylline alone, and also an increase in lung function in these patients. This was a short-term study over 2 weeks. We didn't expect to see any increase in lung function, and we got just under 100 mils improvement in lung function. And as a comparator, PDE4 inhibitors, which are about to be approved by the FDA, give about 48 mils improvement in COPD patients. Okay, so I'll stop there talking about this, but it seems that the effect of theophylline is probably mediated via PI3 kinase delta, which we don't know exactly how PI3 kinase mediates HDAC activity, but it causes post-translational modifications of HDAC2 to somehow affect its activity. May have time in discussion to cover that. There are other diseases which are chronic inflammatory diseases, such as cystic fibrosis, which is one of the commonest genetic diseases in the Western world. And the gene for cystic fibrosis, CFTR, was described about almost 20 years ago now in Montreal. This disease has abnormal CFTR. Interestingly, if you look in the peripheral lung of patients with cystic fibrosis, you see almost a complete absence of HDAC2, but not HDAC1. And if you remove CFTR or take away the activity of CFTR, you again induce a reduction in HDAC2 activity. And this is just a graphical analysis of this data. And there was no change in CBP or P300 expression in cells, in epithelial cells from these patients, or in cell lines where we can change CFTR expression. This has functional consequences, looking at histone acetylation at the IL-8 promoter, CXCL8. If we knock out HDAC2, again with the presence or absence of CFTR, we can modulate promoter acetylation status. There are also changes in other respiratory diseases, and this data is from John Wart, really looking at primary cells from patients with pulmonary hypertension, where combinations of interferons, which stimulate STATs, and TNF-alpha, which stimulate NF-kappa B, can enhance endothelium-1 production, and this is associated with enhanced recruitment of NF-kappa B and histone acetylation at the ET1 promoter. And this is blocked by HAT inhibitors quite successfully, suggesting again that there's potential for intervention in these diseases. In interstitial pulmonary fibrosis, one of the problems is that there's no COX-2, so no production of PG2, and there's also abnormal, so these are fibroblasts from patients with interstitial pulmonary fibrosis. There seems to be abnormal acetylation of the COX-2 promoter, whether this H3 or H4 promoter acetylation. And there's increased recruitment of HATs, decreased recruitment of HATs to the COX-2 promoter in these fibroblasts from IPF patients, and enhanced recruitment of co-repressor proteins. So this data from Alan Knox and Linhua Pang they further went on to show that the inhibition of HDACs using 2 inhibitors could restore COX-2 activity, suggesting here that modulation of the epigenome using HDAC inhibitors could restore COX-2 activity from fibroblasts in IPF patients and therefore have restore function. It's probably a bit more complex than this.